Hi, my name is Colleen LaBelle. I work for Boston University Medical Center and also for the Bureau of Substance Abuse Services. I am the program director for their state office-based opioid treatment program, which essentially is providing training and technical support to 17 at present community health centers that are funded through the Bureau and additional health centers that are going to be coming on board with funding that's coming from HHS from the Opioid Task Force initiative that the governor put out. So I'm here today to talk to you about medications to treat the opioid dependence issue that we have and that we're struggling with in the state of Massachusetts. So this is a billboard actually that the Bureau put out back some years ago, and I just find it's very, pretty much, it's very poignant in talking about, what it is that happens and that people don't make these decisions that they're gonna become an addict. It's not a career choice. It's, something that happens unfortunately, based on people's behaviors and people's decisions to experiment with things. And from that, we're seeing this horrific epidemic that is impacting us. And this here is a map that shows you back in 2005, when you look across the country, it shows you people that are dying from overdoses and those that are dying from traffic fatalities. And in 10 states in 2005, there were more people dying from overdoses than motor vehicle accidents. But we don't talk about that. We still don't talk about it. And as you can see, when you look at the map, Massachusetts unfortunately had this, this statistic. And a few of the other Northeast states were also struggling. So then you take that and you go 5 years further into 2010, and that statistic has gotten even more horrific. And now there's 31 states that have been impacted by this opioid epidemic, more so than motor vehicle accidents. And now in 2015, I think we're somewhere around 37 or 38 states that hold this statistic. But again, when you look at the news and you see what's going on out there and you talk to people, this is not what people are talking about. This is not what's on the front page of the newspaper. No one's talking about this silent, stigmatizing epidemic that's hitting our communities and our families across America. So in 2014, the CDC put this statistic out, which again just really speaks volumes, because we talk about the Ebola epidemic and we talk about other things that are impacting people, and you're talking about 1 or 2 people potentially that have these fatal viruses. But we look at the opiate epidemic, we're losing more than 120 people a day in the United States of America from this epidemic. These are unintentional overdoses. And so this is the biggest public health problem that we are faced with right now. And the one that we're probably talking the least about. It's getting better. And in Massachusetts, we're doing a much better job. Actually, we're a leader in a lot of what we are doing here across the country, people seeing what's happening and seeing even from the era of Michael Botticelli and what he's now doing across the country at the White House. And his impact is really changing the road and changing how we're looking at this disease. And hopefully that is going to continue to spread. This here shows you in Massachusetts, it's always hard to get the complete data as far as how many people have died from an overdose. And the Secretary's office is very committed to trying to get data in real time. They actually just came out with data from 2014 that showed that we're about a little over 1,000 people in 2014. Looks like have died from unintentional overdoses. And again, those numbers are climbing, and it's much higher than motor vehicle accidents. And we had a period of time where the overdoses have stabilized, and that's actually when we did a lot of Narcan administration. Massachusetts, again, much ahead of the curve as far as Narcan administration. We've reversed more than 2,000 overdoses that have been reported. People don't have to report the overdoses now, so we don't essentially know how many people have been reversed. But we know that there's a lot, but with that, we're still losing greater than 1,000 people. And unfortunately, the numbers are not solid, because when you look at Worcester, Springfield, and Boston, they don't get reported in that same database. Comes from the ME's office, and as we all know, the ME's office, unfortunately, is very, very much behind with the amount of medical exams they're doing, so we don't have hardcore numbers there. So this here shows you where this is all happening from. So everybody knows we're talking very loudly about the fact that we have a prescription drug epidemic and that we're over-prescribing prescription drugs. And as much as that's a problem or has been a problem, that problem is really resolving. Providers are becoming more educated. Providers are being required to take training programs, especially in Massachusetts. Some states are not there yet. Again, some of them are a little bit further behind than we are. But in Massachusetts, all providers that have prescriptive authority have to do 3 hours of scope of pain or some type of risk management credits now to actually renew their licensure. And so with that, and with the media and the prevention and the education and what have you that's been going on across Massachusetts, we're seeing less and less people prescribing opiates. And we're also seeing it in other places. Unfortunately, it feels like that pendulum is swinging a little bit too far, and now we're under-medicating folks that do have chronic and acute pain. And people are being stigmatized and treated unfairly that have those issues. And so that's a balance we have to figure out how to fix. But the other piece of this that's really disturbing is as the opioid prescribing is going down, the heroin use is going up. So an unintended consequence of us, clamping down on prescribing and providers thinking about it and not using opiates as the first line all the time and not using them in large volumes, except when they're actually necessary. Like when you walk out from a surgery, you shouldn't be walking out with 120 oxycodones. When you have your teeth extraction, you shouldn't be getting OxyContin. So trying to think differently about all of that is happening. But then those that were either had an abuse issue and got shut off or haven't been able to get it because the resources aren't there and there's less prescription drugs on the street are turning to heroin. So that is very, very, very disturbing. So in Massachusetts, on the governor's task force, the governor is very committed. This is one of his #1 priorities. And with that, there's 4 areas that are being addressed, and that is prevention, intervention, treatment, and recovery. And in order for this to work, this is a complex disease, much like a lot of the other complex diseases that we all treat, especially in the public health sector. You can't just treat one piece, you got to treat the whole person, and you got to put all the resources in place in order for it to work. So when we sat down to try to figure this out, and everybody was coming from different silos and everybody had their own agenda, it was really clear that you couldn't just do this or do that and be done with it. We all had to come together. We all had to figure out how to do this collectively and how to treat each person as an individual with that individualized treatment plan. So drugs are affecting all of us. I mean, none of us can say that we haven't been touched by this. Addiction affects the brain. It changes the brain chemistry. It creates medical comorbidities. People are hospitalized with these infections, with these cellulitises, with this heart disease. They get endocarditis. People end up needing their heart valves replaced. People are getting HIV. Hepatitis C is rampant in substance abuse, as most of us know. Mental illness is obviously a factor here, and folks that are struggling with mental illness that are not getting treatment are a really great risk here. The economy is a factor. Productivity. I mean, we know that 1 out of every 10 full-time employees has a substance use disorder. So if you think about that in your work environment, you have somebody who's struggling with substance use, they're not able to do what it is they need to do, so that's affecting the entire team. The healthcare, cost factors is a huge factor with this. People are being hospitalized. They're then ending up in 6 weeks of, needing to be in a program where they need to get IV antibiotics. They need aftercare. They need skilled nursing facilities. There's just so many pieces to that. And the homelessness, the crime, and the violence, are factors related to someone's substance abuse. And it's not just the person on the street corner that's drinking out of the bottle or that's homeless as a substance abuse problem. This is affecting, affluent communities across America. And in Massachusetts, we're seeing this. We're seeing this hitting areas which never even knew the words heroin or ever thought that that could be, a problem for them. So I just want to people hear the words opiate and opioid all the time, and I just want to explain to people what it meant so that you just had a little bit of a handle on that. Opiates is now something that comes right from that plant. So that's the poppy, and that is a pure form of an opiate. But every drug that somebody uses that has an opiate in it is the same. It works the same way. The others are just manufactured. So there's either fully manufactured or partially manufactured. So some part of it may come from the plant, and the rest of it's manufactured. But they all work the same way. So what we're trying to do is to talk about everything as an opioid. That way it kind of covers everything. The other thing that's important about this, just for people when you're taking care of folks that may have a substance use disorder, is if you're testing somebody's urine and they're abusing fentanyl or they're abusing methadone, and you just do a standard urine test that doesn't have fentanyl or methadone in it, it's not going to show up on the urine screen. So those are the things that are important when you're looking at, opiates and opioids, is testing for the appropriate substance. So historically, opiates have been around a really long time. There were morphine clinics back in the 1900s. And then what happened is the AMA declared that you could treat someone's substance use disorder, which they obviously didn't call it that back then, in your office practice. And so the Harrison Narcotics Act made it illegal to treat addiction. And so these clinics closed down. And now if you can just imagine what happens when you take someone's medication away from them that's now dependent, is folks had nowhere to go. People didn't understand addiction that well. There were only 2 hospitals in the entire country, and it was a greater than 90% relapse rate. So there was this large period of time where people weren't being treated, people were being undertreated. We were undertreating cancer and everything else, and it kind of feels like we're swinging that way now, which is a little concerning. Until like the 1960s. And when the 1960s, Dr. Dole and his colleagues did research around methadone and learned that methadone was an actually really effective tool to treat opioid dependence. And so methadone was actually legalized back in the 70s. President Nixon allowed it to come out in these regulated, federally, guided clinics, which most of us are very familiar with, that have lots of rules and restrictions. And those rules and restrictions still remain there today. They really haven't changed a whole lot, but it is an effective tool. I know a lot of people have opinions and thoughts about methadone, but I would caution you to remember that it is a tool, and that those that you're seeing that are not doing well on it are those the only people you know. Those that are doing well on it are invisible to everybody. And that's the unfortunate thing. Methadone gets the bad slack because they see the people hanging out at the street corner that just came out of the clinic or just came into our place and went to Dunkin' Donuts and bought some Klonopin, and now they're nodding out in their coffee. Those are the folks that are not doing well. Not everyone does well that's in treatment that has a substance use disorder. But there's a lot of functional people that get up and go to work every day and are invisible to all of us. So this was a postcard. This is Mrs. Winslow's soothing syrup, which has morphine in it. And if you can imagine, they were using this for teething for children. Does anyone's house look like that at night? Really cozy. Everyone's totally cool, paying attention to what mommy's reading. But we learn from this. This is, unfortunately, people didn't realize that this was really not a cool thing to do. And some of us grew up remembering paregoric. Paregoric is this liquid formula that it's also a narcotic, it's actually Schedule I, and they were using that to put on kids' gums when they were teething. So you did any of this today, they take you out in shackles, your kids would be gone, your life would be over. But just to let you know, we've learned over time, everyone remembers Coca-Cola for cocaine. And here is Bayer aspirin. Bayer was manufacturing heroin and selling it over the counter to treat your cough. So those of us in the medical field know that that probably worked real effectively, not just because it made the person sedated and high, but because heroin is an opiate. And when you have that really horrible, horrible nagging cough that doesn't go away and that bronchitis, and they give you Robitussin AC, it's not the Robitussin that's doing anything, it's the codeine in the Robitussin, because the opiate suppresses the cough reflex. So I don't think we'll be seeing, Bayer manufacturing heroin over the counter, although Portugal has legalized drugs and has found it actually to be a very effective tool in that it's decreased their crime and their drug use, and people are in treatment. But I don't foresee that happening in the United States anytime in our lifetimes. This is a pretty, primitive picture. This is your brain on drugs. Those of us who have been around remember this from the 80s. And, it's primitive, but it's kind of real when you really stop and think about it. Opiates change your brain chemistry. That is real. And so when you stop and you think about this disease, it is a disease. It has all the same characteristics as the other chronic relapsing diseases that we treat every day. And when you don't treat it, it progresses, and it can be terminal. People die when we don't treat their terminal diseases. And so it's not that easy for that person who has now become dependent on that drug to just stop. So we all have a control center in our brain. It's our midbrain, and it remembers things, and our frontal lobe processes things. And what happens in the addict's brain is that midbrain becomes changed, and it needs that drug to feel normal. So it's no longer a conscious choice for that person not to use that drug. And what it is that gets let go and gets released and makes people feel good is the dopamine. So we all get dopamine surges. We need dopamine. Dopamine is a normal part of life, and it sustains life. We need to have pleasure in our lives, from people, places, things, children, activities. But unfortunately, with opiates and with an addiction, is your brain actually gets more of a dopamine surge than it would with normal pleasurable activity. And so that's where the rub becomes the problem. Sorry, just go back here for a second. So you think about the person. So say you walk into Disney World. Walk into Disney World, we all get excited, right? It's just very euphoric. It's a wonderful place. The children are having fun. There's all this excitement. The person with addiction walks into Disney World and they feel flat. They're like, I don't get it. What's everybody all worked up about? Why is this such a great thing? And it's because their normal's up here now. So normal's here for us. We're feeling good. The person who used the drug, that receptor got set to a higher level. So in order to feel good, they need to be up here. So without that drug, they feel flat. So if you just imagine not getting pleasure. So you had a substance use issue, you stopped using, and now you feel flat. You have no pleasure. I mean, that's a pretty horrible place for someone to be. And unfortunately, that's what happens with addiction because of the brain change. So just in comparison, just to try to think about this more, because a lot of people struggle with this. I think everybody does until you work with this or you get more of a sense of it. This is a disease, and the problem with it is that it has a behavior associated with it. Okay, so people say they made that conscious choice to use that drug. They made that decision. They made that bed, let them sleep in it. Okay, so you think of the diabetic. Most diabetics, they may have diet issues associated with the disease. It may be genetic, but it may be diet associated. They may not be taking their medication. They may not be eating the way they're supposed. They may not be following up with their appointments, checking their blood sugars. So their diabetes goes in and out of remission. They're relapsing, but we never say that, right? So now their kidneys shut down. Their blood pressure's high. They're not maintaining well. They need toes amputated. They have these acute problems related to their disease, and a lot of it is based on their behavior. Not all of it all the time, but a lot of it can be. And we don't judge that person. We don't treat that person differently. How about the hypertensive patient who now knows they have hypertension, who's supposed to follow a diet, who's supposed to take their medication, who's supposed to walk every day, who's not supposed to take salt in, who shouldn't be drinking. And now they just drank 2 12-packs to watch the Pats win the World Series or whatever. Sorry, just lost that. But anyway, they watched the Pats win the Super Bowl, and in doing so, they drank 2 12-packs. They got chest pain. They ended up in the emergency room. They have already had a stent put in. No, they just had bypass surgery. Now they need another stent. Do we judge that person? Do we not treat that person? Do we tell them they had a relapse? Or do we treat that person who's in an acute crisis who could die if we didn't treat them? We treat them and we don't even think about it. And what about the asthmatic who continues to smoke, or who smoked all their life and now they have really bad COPD and now they have asthma? They come in, they can't breathe, they need an inhaler, it doesn't work, you do a NEP treatment, it doesn't work, they need to go on a vent. We treat them because we know they're going to die, right? So all those folks have behaviors associated with their disease. It's not always their complete reason for their disease, but they have behaviors and genetic components in some of them. The same as the person with addiction. The problem with the person with addiction is their behaviors are really horrible. We can't stand their behaviors. There's no doubt about it. It's horrible, horrible behavior. They steal, they'll take from their grandmother, they'll hold up a drugstore. They will do whatever it takes to get that drug to manage their disease. And that's their brain that's telling them they need it, and they can't go to their local CVS and buy heroin. It just doesn't work that way. So they have to manage their disease, and in doing so, they engage in some pretty horrible behavior. So I don't want to, say that's okay because it's not, but I think you got to stop and separate it. It's not the person you don't like, it's the behavior. So when you take that drug away from that person and that person's in treatment, that person's usually a wonderful person. Think about the alcoholic. A lot of us know alcoholics, right? And alcoholics typically have a great time. And when you take the drug away and you get them into recovery, they are great people. But when they're drinking, you can't stand them. They are just like your worst nightmare. You don't want them at the party. You don't want them to come to the family reunion because they're going to ruin everything. It's the behavior. It's not the person. And so just trying to, separate that when we're struggling with this disease, which will tear on your heartstrings and really, push everybody's buttons. So what happens here? So I started talking about this. So when the person uses, they get euphoric. So person's at a party, teenagers at a party. They got the pill thing going. People are sampling pills and trying different things. They take that pill, and what happens? They get high. What happens when you drink that alcohol for the first time? You get high, or you use that other drug or whatever it is you're going to try. You get a euphoria. You get pleasure. So they go back the next weekend. They try it again. They're looking for that high they felt the first time. People are always trying to get back to that euphoria because it's usually the best feeling they've ever had in their life. And people will tell you that. They'll say, oh, my God, and they're chasing that high. I just want to feel what I felt last time. But over time, they'll use again and again. Their body now needs the drug. So the more they do it, the brain starts remembering it. That midbrain's like, I like this. I want more. But as they do it, their body develops a tolerance. So now they need it. And when you take it away, they enter that red zone. So when that medication, that drug, it's not a medication when it's being abused. When you take that drug away, they go into withdrawal. When that person goes into withdrawal, they are physically sick. It's like the worst flu of your life and no one wants to be there. So what they're going to do is try to use. But the person who uses opiates are short acting. The opiates people like to abuse, not the MS Contin, people, or the fentanyl the way it's supposed to go. That's not what people want to abuse. They want something that's going to give them a big bang for their buck. That's why they used to take the OxyContin and they would melt it down and get the entire 80 milligrams that's supposed to be over 12 hours in one shoot. That's what they're feeling. They don't want that pill that's keeping them at a level. So when they go in and out of that withdrawal every 6 to 8 hours, they have to use again. So somebody who has an addiction has a full-time job. They have to figure out how they're going to use, when they're going to use, where they're going to get it, how they're going to pay for it, and how not to enter the red zone. And then we'll see some of our patients that will come in to see us, they're sitting in the waiting room, and now they're gone. Where'd they go? They started going into withdrawal. They couldn't wait for you any longer. They had to leave. And so, but they're only using now to keep from getting sick. So just imagine that. So now you're spending your whole day trying to get drug to keep yourself from being sick. And a lot of our patients that have been using 30 and 40 years will tell you that. We love our long-term heroin addicts and they're not using anything else because they just don't want to do this anymore. And they don't want to be sick. And so to give them something that manages that is like a godsend. So this is what happens. So here's your brain. Somebody uses, you get high, you have a good time. Everybody does things that are not good for us, but it doesn't always change your brain. But unfortunately with addiction, it actually literally changes your brain. So that's what happens. That's your midbrain. So this is the control center. It's telling us, and the midbrain saying, that was good. I want more. Send more. I want more. I need that drug. And that brain's literally screaming at that person when it no longer becomes voluntary. So that's when that person needs that drug to feel normal and engages in horrific behavior to manage their disease. So here, again, it just shows you that. So here you are, the normal, the euphoric, and over time, it decreases, and they're just in a phase where they're maintaining. Does that mean everyone who's using substances out there isn't getting high? No. Unfortunately, they may be maintaining on their heroin, but then they're putting other things on top of it, which is what I think we're all struggling with, And so you have that person who's on methadone, or you have the person who's on Suboxone, and they may be taking those meds, but then they're, taking gabapentin, and they're, taking Klonopin, and they're adding other things because unfortunately, people who have substance use disorders are smarter than we will ever be, and they are little chemists, and they have figured out what to take and what enhances what and what's going to cause what euphoria. And that's unfortunately what a lot of us are seeing that we need to respond to, because that's the stuff that's really harmful for folks. So when someone does use, so I talked about they go into that red zone, they have that physical withdrawal. So we say, okay, fine, send them to detox. So they go to detox. Detox isn't treatment. And I just wanted everyone to always understand that. Detox is detox. It takes a substance out of your body, but now you need treatment. So when that person comes out of that detox, that brain is still screaming at them. Remember, that receptor has changed. That brain is screaming for that drug, and they have the long-term effects. So they have muscle ache, they have pain, they can't sleep, they can't sit in their own skin, they're uncomfortable, they're anxious, they have no pleasure. So that person is absolutely miserable. And that's called protracted withdrawal, and that can go on for months or years, and so that person needs treatment. Does that person need medication? Not everybody, but a lot of folks do. But on top of that, they need counseling. They need to figure out how to live without the drug. And that's the really hard part, is how do I live my life without using a substance? And patients, don't know how to do that, or can't, or don't have the skill set, and that's where they need our guidance and our support. The detox is the easy part. Getting them through that first part of it, it's the after piece that's the struggle. So I know we're not talking about adolescence, but I think adolescence is important to all of us. Excuse me. So adolescence, whether you have adolescence, whether you know adolescence, whether your family, wherever, it's important. This is prevention. We're all public health workers. We all take care of the public. And we need to do our job as best we can. It's trying to get messages out. Adolescence is the most challenging time. And anyone who's ever had a kid or has children will tell you that I don't know what happened to my kid who took their head, swapped it, and sent somebody else home. Because they engage in behaviors like this. But when we all stop and think about our adolescence, you think about crazy stuff you did, right? You think, oh my God, how did I make it? I don't understand. Or you think about other people that did it. But adolescence is a time when your brain's literally going through changes. And you don't think rationally like an adult thinks. You don't think of the consequences. How many of us would jump off that bridge? I'd be there, okay, how deep's the water? Is the tide out? Are there rocks down below? I'd have to check all that out. Where are the boats? These kids aren't thinking about that. They're thinking about, oh my God, big energy, lots of bang for my buck without a lot of exertion. And my friends are doing it, okay? That's all. Not, my mom's not doing it, but my friends are doing it. So it's not about consequences when you're an adolescent. Everything is impulse driven. You're not, this kid's like, no gear, no nothing, out on the street on a skateboard. Like, can you imagine? He's not thinking about whether the car stops, whether he rolls under it, whether it hits brakes, whether something comes from behind. That's not where his brain is. And that's because his brain is an adolescent brain. The adolescent brain, if you look at the brain on the right, is using the amygdala component of the brain. That's the impulse part. Biggest bang for your buck. What does an adolescent want to do? They want fun, and they don't want to do anything. They don't want to do the laundry. They don't want to do their homework. They don't want to mow the lawn. They want to play games on their computer, on their iPhone, and they want to, do fun things with their friends. But it's normal. It's frustrating, but it's normal. An adult who's grown and has a mature brain is using their frontal cortex, and they're processing and judging and thinking through things before they do things, or at least we hope they are. So this just shows you, and this is why this riff is happening. We have learned through science that the adolescent brain goes through this change and all the neurons slough off and they rebuild and they get stronger and more effective. And when that brain is finished developing, that brain will be faster and more efficient than any of our brains. However, that time period doesn't actually happen until the early 20s are complete. And the last part of the brain to develop is the frontal cortex. This is why when we try to reason and rationalize with adolescents, we struggle so much, because that's not where their brain is at. They're functioning off of impulse. So, we say kids can move out, they're 18, they can go to a war, they can vote, they can do all these other things, but in reality, their brain is still developing. And so that's really important to think about, because when you talk about addiction in that adolescent, picks up a drug or an alcohol in that time period when their brain is still developing, their risk of developing addiction is so much greater. So we know that the adolescent who uses substances between 12 and 17 is 67% more likely to become addicted. And even between 18 and 25, they're 26% more likely to become addicted. So it's not just about telling kids what to do, it's about trying to guide them for the rest of their life. You're trying to help them make good choices so that their life doesn't become impacted by substance use. And that's a really hard thing to do because, again, adolescents don't listen to us. They don't think we know anything. They think their parents, somebody swapped their head, and they want you dropping them at their corner, and their friends know everything now. So unfortunately, this is a hard thing to do. And again, the HHS secretary is really committed, and as people have started seeing the PSA announcements that are out, really talking about prevention and education, and there's going to be a lot more coming and a lot more education. And education is actually going into the schools where it's going to be mandated that addiction education has to happen, some type of an evidence-based curriculum in every school district. So how do we treat this? What do we do? So when someone, if someone gets to the point where you haven't treated them and have started using substances, you have to treat them. Can they go without medication? Some people can, but most people cannot, unfortunately. So that mu receptor, that's your pleasure center. That's the thing that gives you the biggest bang for your buck. So we have a full agonist, we have partial agonists, and we have antagonists. And so we'll talk about those three. So your antagonist is something that's going to block your receptor. So remember, your mu receptor is your pleasure center. Somebody who has a substance use disorder, you don't want them to use. That's the goal. You don't want them to use that substance. So if you can block that receptor and keep them from using, that sounds like a good thing to do, right? So there is a medication that you can give somebody that does that, and that's called Naltrexone, or otherwise known as Vivitrol. So what that drug does is when you give that medication to the person either orally with the tablets on the top right or by injection with the injectable on the bottom right, you're going to block that opioid receptor. So that person goes ahead and uses, they're not going to get any effect. It's somewhat like antabuse for alcohol, but antabuse actually makes somebody sick if they were to drink. In this case, it will just block it. So the person takes their medication in the morning, then they go and inject heroin, and they're not going to get any benefit. They're not going to feel any effect. So the naltrexone formula is the oral. That's a tablet. So somebody can take that in a tablet formula. And anyone who has prescriptive authority can prescribe it. It's pretty safe. Some people get some stomach distress with it, but it's a really pretty safe medication. The hard part about this is keeping somebody taking it. And so people will just get up in the morning and make a conscious decision, I'm not going to take my naltrexone today. I'm going to get high this weekend. So if you have a spouse or a family member, or you're in a program or in, somewhere where someone's administering your medications, then that helps your chances of continuing the medication. But when you're on your own and you have a disease that affects your brain, you might make the wrong decision and stop taking the medication. So what the company then did is they changed and made a new formula called Vivitrol, and that's the injectable formula. And the injectable formula can actually be used for opiates or alcohol, which is kind of a nice thing. It has to be given once every 30 days. It's a pretty big injection. So people in the medical field, it's 3.4 mLs, which is substantial. Usually we don't go over 3 mLs in an injection. And it gets given in the butt. It's a deep intramuscular injection. It's pretty safe. It is expensive. And if somebody were to use on top of it, they're not going to feel it. The problem is you can't give it to somebody if they're using. They have to come off the opiates first, and there has to be no opiates on the receptor, or you're going to make them really, really sick. So that's the challenging part about it. It is once a month. It gets refrigerated. It has to be given by a physician, a medical provider, and you need to get approvals for it. But all the insurers in Massachusetts, I should say all the insurers except self-insurers, is some that may be a little bit quirky, will cover it. But a lot of times it comes from a specialty pharmacy, which is a challenge because it has to be delivered and it has to be refrigerated. But the straight Medicaid, standard Medicaid plans all cover it, and you can purchase it, like you can go get it at CVS. And so that is so much easier to deal with. At BMC, we actually do it through our internal pharmacy, so patients don't have to deal with that piece of it, just to take that loop out, but it's definitely a challenge in the ordering process. So then there's a full agonist. A full agonist is something that totally occupies that receptor. So remember, that receptor is the pleasure center in the brain. And if you give somebody a full agonist, the more they take, the more effect they get. And those are typically the drugs our patients who have opiate dependence like to abuse. Now, methadone I put there only because methadone is a full agonist, and it can be abused in different formulas, but it's not typically a medication patients would like to abuse because it's long-acting versus short-acting, so it's not going to give them that same euphoria. So again, the more somebody uses of a full agonist, the more effect they will get on that receptor in the brain. And that can be risky because they can have an overdose with that medication or that drug if they're abusing it. So with methadone, we know it's evidence-based, and we know that it works effectively. It's given in a controlled setting, or it's given, some people do have take-homes, or maybe in a program where they get their medication brought to them. It has counseling and therapy associated with it, and people have individualized treatment plans. It is a hard system. You know, people have to get up every day and show up, and they have to live near a clinic or be able to get to a clinic, and that can be challenging. When someone takes it, so the patient shows up in the clinic and sees the nurse in the morning, she lays eyes on them. A lot of people need that. For a lot of people, it's a great therapy because somebody's laying eyes on them. They're not just left to their own devices. They see it and they look okay. They give them their medication. They swallow it. They have to speak after they take it, so you're sure that they took the medication. And usually within 30 to 60 minutes, it starts having an effect. People say they just went to the methadone clinic and now they're wasted. Well, if they're wasted after they left the methadone clinic, A, their dose is too high, or B, they did something between the methadone clinic and when you saw them. And what I say to providers, to anybody who's seeing this with patients, is we need to do something about that. We can't just keep taking a backseat and saying, oh, they're wasted because they're on methadone. They shouldn't be wasted on methadone. And if they are, like I said, their dose is too high or they took something else along with it. So when this happens and someone calls and says, hey, one of your patients is in the waiting room because somebody's out there nodding out, and I go talk to them and I figure out if it's a patient that belongs to the methadone clinic, and that's a patient of ours, then we get a release and we call the methadone clinic. And we're not calling them to rat them out. Something's wrong. We need to figure out what's wrong. And the unfortunate thing with methadone is it's separate from the medical system. It needs to be integrated. We all need to be working together to try to help our patients. So we know that that person's not safe, that something's wrong. That person should not be nodded out, sedated, can't stand up, can't have a conversation. And so either their dose is too high, they took something else, and that either the methadone clinic doesn't know about it, because they're not seeing that. Remember, they saw them first thing in the morning, they looked good. Now their medication is peaked a few hours later. Maybe their dose is too high. Or maybe they took something on top of it that bumped its effect, and now they're wasted. And so if that's the case, we need to get at that so we can keep that person safe. So talking to the medical staff and working as a team is the only way we're going to help our patients. And so I always say that to patients. People are always yelling and screaming about the methadone clinic. Have you talked to them? We need to connect those systems. Lots of stigma, around methadone. This is a picture from the lovely Herald, which annoys me on a regular basis. But back in 2005, they went in front of Topeka Street, which is down near Boston Medical Center, and they took a picture of people standing outside the methadone clinic. Now, methadone clinics are typically on side streets. There's not enough room for people inside. They're standing in lines. There's a lot of things like that with methadone that can be a struggle. But these guys had their, 18-wheelers parked out in front. Harold came along, took a picture, and said, this is why the big dig's leaking, because the junkies built it. Really? And this is what horrifies people about these systems and why people don't want to go to methadone clinics, because of this type of a stigma. These are functional people that are getting out of bed every day and going to work, and were invisible to all of us, other than the fact that someone saw their truck. So just, people need treatment. Treatment works, and we have to stop judging the treatment and what is needed for someone's recovery. So what medication does do is it's not, replacing one illegal drug for a legal drug. It's replacing a change that's happened in somebody's brain. It's like giving the insulin to the diabetic who has pancreatic issues related to their disease. It's fixing a brain change. It's taking the withdrawal away. and it's making the brain work better, and it's taking the cravings away. So that person's not running around chasing a drug all day because their brain is screaming that it needs it, or they're physically or mentally ill related to their disease. So when we look at methadone clinics, this just shows you nationally, this was in 2009, I don't have an update, I apologize, but there's not access to methadone everywhere. Massachusetts is very fortunate. We are very innovative in our treatment, and we have lots of methadone clinics, and we have satellite clinics. We do have a few holes in the state, maybe like in Martha's Vineyard and Nantucket, and then in rural areas in Western Mass, where it's a bit of a distance for someone to get to a clinic, which can be a barrier if you don't have a car and there's no public transportation. But for the majority of it, we actually have really good care. But in other states, it doesn't mean they don't have a need and they don't have a problem, but they don't have to allow treatment with methadone. And some states have made that decision not to allow methadone maintenance. So buprenorphine is the medication that's come about more recently than methadone and is being used differently. So what happened in 2000, so remember me talking about the Harrison Narcotic Act, which made it illegal for you to get to treat someone's addiction in your practice. What happened in 2000 is the Drug Addiction Treatment Act came about and stated that patients could now be treated for their opiate dependence in your practice if they had a medication that was a Schedule 3, 4, or 5, and the medication was regulated for the purposes for opioid maintenance or detox. So it doesn't mean any drug that's a Schedule 3, 4, or 5 you can use. It has to be approved for that purpose. Now, this does not change methadone. Methadone is a Schedule 2, so the regulations around methadone have not changed. The rules around methadone have not changed. The thing with this that is also different is that it can only be prescribed by a physician. The physician has to be licensed and approved to prescribe the medication, has to have what we call an X number. So they have to go through an additional training that will then give them an additional DEA number. They can treat 30 patients for the first year, and then they can apply for an extended waiver for up to 100. So unfortunately, it's the only treatment that physicians are limited by how many patients they can treat. But the concern was we wanted to do this safely and correctly, and we didn't want to create pill mills, and we wanted patients to get evidence-based care. So I think that was the reason this happened. Why NPs and PAs weren't allowed, I don't know, but there's a lot of issues going on right now, and Senator Markey actually has the TREAT Act that's being looked at, trying to add in NPs and PAs, and also to increase the numbers for physicians so we can get some more treatment out there. So buprenorphine is a partial agonist. So we talked about a full agonist and we talked about an antagonist. Buprenorphine is a partial agonist. You got your mu receptor, your pleasure center. If you take buprenorphine, it only partially attaches to the receptor. So that makes it a safer option. So it's going to be less abused. If somebody wants to get high, they're not going to be using buprenorphine. They want something that's going to give them the biggest bang for their buck. Buprenorphine is only going to partially work. So the more you take, it doesn't go higher. So more is not better, which is a hard concept for all of us to wrap our heads around because we all think more is better. But it's kind of like taking your vitamin C. If you take your vitamin C and you take more of it than you need, your body just excretes it. You do the same thing with buprenorphine. Your body's just going to excrete the drug. It's not going to hold on to it. So patients don't have a really good reason to take more of it. Can they take things on top of it and make themselves high? Absolutely. And that's unfortunately what people do with this and other medications. So even though physicians are the only ones that are prescribing the medication, this medication will not work, this treatment, without a multidisciplinary team approach. Much like methadone, substance abuse, mental health, we need the whole team to make this happen. And so the doc prescribes it, but the nurses in a lot of these clinics are the ones doing that day-to-day management. Counselors are seeing them and doing the therapy, and we're working with all the other extended treatment arms with that patient. So the team effect is what helps and what works. This is a complex chronic disease that requires lots of different venues to get the person what they need. So the other tricky piece about it is the person walks into detox. People typically go to detox, they walk in the door, they get medicated. You just start medicating them, they're chasing the nurse down the hall. They want every medication that's in that order that they can have. to manage their withdrawal. If that detox is using Suboxone, otherwise known as buprenorphine, you can't just medicate them. So say the person walks in there, they just use 2 grams of heroin, and they're going to use a Suboxone protocol. If you were to give them Suboxone, you're going to put them into withdrawal. So you actually have to wait for the heroin to start coming off the receptor. So typically when somebody uses, they use something that's short acting, so it only takes like 6 or 8 hours or so, starts coming off, and we start titrating the Suboxone on. It sounds complicated. It freaked a lot of doctors out in the beginning. People didn't want to do this. Oh my God, people are going to be in my waiting room. They're going to be sick. They're going to be vomiting. Patients can do this better than we can. It just means, we'll say to patients, Sunday night, use your last time and come in on Monday morning. They come in, we assess them, they get started. I mean, it's clear, it's actually that simple. But again, we want to make sure they're in withdrawal before we do that. When they take their medication, it gets given a little differently. It goes under the tongue. It's a sublingual administration. A little different. It's like giving someone nitroglycerin. So it's a pill that goes under your tongue and dissolves. Takes a period of time. It can be chalky, it can be bitter, it can make some saliva. So it's a little tricky, and people have to get used to that. It usually starts working within a couple hours, but the level of the medication builds over hours and actually doesn't come to a full effect for like 3 to 5 days. So if you're changing if your doc or someone's changing someone's dose and they say, well, I don't feel any better. Well, it may take them a few days to get that full effect. And so they need to kind of be patient, and working and supporting them through that is really important. So when you're giving someone Suboxone, again, it's much like your full agonist. It's going to take away the withdrawal, it's going to take away the craving, and it's going to help return the changes in that brain. So here's your patient who's using heroin. The receptor is really happy. It's like a lock and key. So you put the key in the lock and it opens the door. That person is getting the biggest bang for their buck. They're getting what it is they wanted to get. So that person, is on the street and someone says, here, try one of these. And they take a Suboxone. This is what happens. The Suboxone literally kicks the heroin off the receptor. And you say, well, why does that happen? It's like a partial agonist. The other one's a full agonist. Suboxone is actually stronger. It's got more of a super glue effect. So the Suboxone is going to kick that heroin down. And what's going to happen is that receptor goes from being way up here to further down. It's a less of a euphoric effect, and it drops the receptor. So when it drops the receptor, the person feels withdrawal. So somebody who's using doesn't want to take Suboxone. That's the bottom line. Somebody who's in withdrawal, somebody who's dope sick, so to speak, I hate that word, but somebody who's having withdrawal symptoms, stopped using, is not going to get sick when they take it. It's going to replace the receptor, take away the cravings and the withdrawal. But you don't take it when you're actively using. So the other thing that's kind of nice about it is it sits on the receptor and it holds on for a long period of time. It's got like a 37-hour half-life. So Johnny's been on his medication, he's doing really well. He's feeling good. He's not craving. He's not having withdrawal. He's going with meetings. But he bumps into Joey on his way to his session. Joey says, hey, you want to get high? Sure. People, places, things. It's not craving. It's not withdrawal. But it's what he knows. So what does he do? He tries to get high. So he uses heroin. But what happens, remember that heroin is strong. That buprenorphine is stronger than the heroin. So the buprenorphine holds on tight. The super glue is still working. And it's not letting that heroin attach to the receptor. So all Johnny gets is pissed off that he just used and he didn't get high. Can he keep using to try to break through that? Absolutely. But first of all, he's wasting a lot of money and he's putting himself in harm's way. But most folks aren't going to do that. Unfortunately, what they'll do instead is not take their Suboxone. And that's what some people will do. Friday I wake up, I'm not going to take my Suboxone today. And then Friday night, I'm going to get high. And I'm going to get high all weekend. And then I'm going to wake up on Monday morning. I'm going to feel a little withdrawal. I'm going to take my Suboxone and I'm going to go to work. For some people, that's a great thing to do. And they really are enjoying that and having a good time with that. That is really unsafe. And that's why people need to be monitored and we need to keep an eye on people. This is a disease that affects the brain. People don't always make good choices. So we have to monitor them to help them in their making choices and changing their behavior. And as we all know, changing behavior is the hardest thing we all do. You know, how often you start the gym on January 1st and by the 10th you're no longer going. Behavior change is hard. And so when patients pick up and they start and they stop, they're putting themselves at risk for an overdose. So if somebody's not using opiates for 3 to 5 days and they pick back up, their risk of overdose is so much greater. And so that's the really scary part about that person who's a weekend warrior who starts and stops their medication. So this just shows you, so when I was trying to explain this to you, when you take it, you put it under your tongue, you see those 2 little white lines? That's where it gets, that's how it goes into your system. It bypasses your stomach. It gets absorbed through those veins into your system without going through the stomach. So it works faster than if you were to take it and have to swallow it and wait for it to get absorbed and all of that. It's not going to work as fast as sticking a needle in your arm, but it's definitely working faster. And that's what, it's just a tricky thing to do. And there's both the tablet and the film, which I'm going to show you on one of the slides. Both of them are the same medication. They're just different formulas. So buprenorphine is pretty safe, pretty well tolerated. It's much like other opiates. It doesn't cause a whole lot of side effects. You can get some headaches. Usually they start in the beginning and they usually go away. If someone has a history of migraines, they're more apt to get headaches. Constipation, we saw a ton of this when we first started giving this medication because we were asking our patients, how do you feel? How do you feel? Do you need more? Well, that was a dumb question. So everybody needed more, and everybody ended up on 32 milligrams, and everybody was having a little business on the side and selling some of it off, and everybody was constipated. So we learned that didn't really need that. The nausea, so if you can imagine putting a pill under your tongue and it makes all this saliva and it has a chalky taste, it's first thing in the morning and you haven't had your coffee. So it can make people feel a little nauseous, and hopefully for most folks that gets better. The anxiety piece, so when some folks use drugs, people are self-medicating. We know this. People self-medicate all the time. When you feel horrible, you're going to self-medicate, which is why a lot of our patients, with mental illness and substance use are using drugs. So they may have an anxiety disorder that wasn't being treated, but the drugs they're abusing were treating it. So now you're seeing this, you've got to treat it. You've got to figure it out because you're going to lose that person. Sweating, we saw a lot of this when we were dosing at high doses, but we're not seeing so much of it anymore. And insomnia is not a really big problem. People typically can sleep okay on it, but we have seen it in a few cases. The pain, I would encourage anyone whose patient is now telling you they're having pain to get them seen. If they weren't complaining about pain before and now they are, there may be something going on that they were self-medicating and didn't even know. We actually had one gentleman who was one of my HIV patients, because I did HIV for like 20 years, who got on the medication, felt like he had finally got his life together, but was having horrible pain. He had lymphoma, but we didn't know it because he was using 3 grams of heroin a day, which was masking the pain. So again, if the pain is new, you need to make sure you're getting it worked up to make sure there's not something else going on. Side effects, liver enzymes, this was something that really got worked up in the beginning. People were worried about this with this medication. It's been pretty safe. There's a little bit more of the liver toxicity issue with the Vivitrol, so you definitely want to be checking those before you're starting the Vivitrol. With buprenorphine, there's some enzyme elevation, and if there is, you just want to monitor it as clinically indicated. Vomiting, again, can be a horrible side effect, but it's like less than 1%, and if it happens, you may not be able to get that person through that, because it can be very challenging. Most medications, there's not that drug-drug interaction that we see with methadone. And we don't really need to adjust dosing. Some patients that are on HIV medications, there may be a little bit of an issue with some of the antiretrovirals, so you work with the ID docs on that. But again, not a huge amount of need to adjusting doses. CNS depression, you shouldn't see it. People should not be sedated on this. And if they are, maybe their dose is too high, or maybe it's interacting with something else they're taking. And rashes and hives and bronchospasm, we don't see this. We've seen a few people with like minor rashes that have resolved. But it's a pretty well-tolerated medication. It gets absorbed orally. It gets excreted through the urine, so you will pick it up in a urine screen. It can be abused intranasally. Most patients won't use it this way because it's very toxic to the nasal cavity. It burns, and it's only a short-term euphoria, but they will get high. I mean, people are creative. People will use it rectally as well. People will use medications in any way that's going to give them a euphoria. So just to be aware that that can be a factor. The risk of overdose with this medication, when used alone and taken correctly, is really low. When you combine it with other things, you're going to get into trouble. And this is what we see with all of our patients. You know, patients are combining benzos and amphetamines and alcohol and cocaine. And when they do that, that's typically when we see an overdose. But if somebody's on a prescription for both medications, it's really important that they're monitored even more closely because of the factors that can suppress the central nervous system. So there were deaths associated with this in France. We haven't seen a lot of it, although when you look at the ME reports and you see the combination of medications, I would say we are seeing it, just hasn't been reported. So alcohol, you know, so you have your patient, we start them on the medication. They have used alcohol 30 years ago, but they've been using opiates for the last 30 years. So now you're managing their opiate problem, they're taking their medication, they're doing well, their alcohol may come back. You know, and so you have to be aware of that. You know, so if a patient starts drinking, we need to address that. We need to see them more often. We need to do breathalyzers. Maybe they need to go to detox. Maybe we need to change what we're doing and they need another treatment option. So being sensitive and aware of that is really important. Sorry. Oops, now it's not going to go. So we want to monitor our patients. So patients, you know, when we're treating patients for anything, you should be monitoring them. It's not good practice not to keep an eye on what's going on with our patients. And even if you're doing that as a provider or if you're doing that as a support person or somebody who's managing them in a program, looking at our patients, seeing how they're doing, are they taking their medication? Is their behavior changed? Are they going to their appointments? You know, do they look like they're potentially using? Is something not going on right? So keeping an eye on changes in our patients and in the public is really important because those are the things that help us grab them when something's up before we lose them. So it's not about catching people. It's not about kicking people out of care. It's about trying to help folks before that train runs off the track. And so when we're managing patients on these medications, we see them often so we can check in. So we can do a urine screen. So we can see. Patients who struggle with addiction have a really hard time telling the truth because they're so afraid of what's going to happen, and they're so used to telling the lie to get through what it is they need to do. So when you get that urine, you can have that conversation. It's like, okay, so urine has cocaine. You want to talk about that? Not you used cocaine, we're going to kick you out. That's not what we're doing here. We're trying to figure out what do we need to do different. You know, do we need to pick up the phone and call a counselor? Do we need to come in more often? Do they need to go to a day treatment program? Is this not working? Do they need to go to methadone? Do they need detox, residential? It's about trying to help figure out the right treatment for that person. So this is the film which I talked about. So both medications, the pill and the film, are the same medication. And the only reason, and actually there's one that's a buccal mucosa one that I haven't even seen yet, but it's just about who's manufacturing it. This one's actually a little easier to take because it dissolves faster and it doesn't make that huge amount of saliva that we see with the pill. And the only difference is what the insurance is paying for. That's all I care about. Who's paying for it, that's what we're ordering. And so it's about getting the patient what their insurance will cover. And unfortunately, they're all over the map. We have Medicare plans. Most of the Medicare plans, I think, are paying for the film right now. And a lot of the standard Medicaid are paying for the pill. And then some of the others, like HealthNet and Celticare, are paying for the film. So again, it's just whatever the payer is paying for. This one comes in an individually packaged, like if you've seen those, the dental strips, like the teeth whiteners that come in those foil packages, that's what this comes in. It's like you got to fold here and then you got to tear down here to take it out. Each one is individual. And the reason for that was safety. At least that's what they're saying. But the reason is safety, because now you're not exposing children. We were having issues, and we're still having issues with all opiates, unfortunately and unbelievably, with children getting it in their hands and in their mouths. And if you can imagine, this medication is absorbed orally. So kids, what do? Throw stuff in their mouth, mom pulls it out, but they may still have gotten some of the medication, and that's where the issue is. So with this, it's safer, it's not out, the kids can't see it because the tablets were orange. You know, they're kind of attractive. Kid sees an orange tablet, it looks like candy. It's chalky, it's bitter, they stick it in their mouth, they may actually like it for a few seconds, which can create a lot of danger. So yes, there's misuse, abuse, diversion, not just around this medication, but around lots of things, but we want to provide treatment that is safe and appropriate. And so if we're getting reports that there's diversion, we need to respond to it. But you hear people say all the time, it's on the street, they're selling it. Well, less than 5% of the doctors in this state are waivered to provide this treatment. We know that we can't meet the demands of the people needing treatment. So if there's a need, there's going to be a resource, right? So drug dealers will sell anything. We had a patient the other day who came to our clinic, we saw them, and we learned that he purchased 2 urines downstairs, one after the other, when we were seeing him trying to figure out what was going on, for $20 a piece. Drug dealers will sell urine. They'll sell anything if it has a market. So there is buprenorphine on the street, but you're not going to go, when you hear a drug bust, you don't hear them busting them with grams and grams of buprenorphine. It's usually a couple of tablets. And I'm not trying to minimize that. We don't want this medication on the street, clearly. We don't want any medications on the street, but they're being sold. So we want to treat people safely. If we hear that something's going on, we'll respond, we'll bring somebody in, we'll do a pill count, we'll give them small scripts, we'll try to figure that out. But usually it's because someone can't get the medication. They are trying not to be in withdrawal. They don't have the money to go get the medication. The docs they know of in their area are only charging cash. And that's another problem. And that's why the state's really trying to do, this huge effort of trying to get more and more treatment into the community health centers so we can have community providers that are treating patients, taking their insurance, and we don't have this concern about diversion and our patients paying cash. So this is just an educational brochure, and these are actually at the BSAS clearinghouse. And I didn't take the other picture, I apologize. But anyone who's on this medication and lives in a house with any children should have this brochure or has children. Because, again, kids get their hands on this, they put it in their mouth, it's oral, it's absorbed, and they're going to put themselves potentially in a respiratory distress. So if child gets this, they need to call poison control, they need to call 911, the child needs to be seen and evaluated. So we put this together from all the OVOTs, all the community health centers back a few years ago, and we give this out to our patients in English and in Spanish. So this just speaks to what I was talking about. So there's only 4 to 5% of the doctors in the entire country that are waivered to prescribe this medication. In Massachusetts, we're a little bit over that, but there's 38,000 doctors in Massachusetts. There's only 1,500 that are doing buprenorphine. If you took that and you cut it in half of them are not treating very many or taking cash, and then you've got like 700 providers. Not a lot of people to go around, and some of them have, only small practices or don't want to treat anyone other than their patients. So the ability for folks to get treatment is very challenging, and we're trying to do a better job at improving that and providing it, again, into the community health centers so that that's not a problem for our patients. So addiction is challenging. Treatment is challenging. Getting somebody through those 5 years is really challenging. But we know that if somebody can get through 5 years of abstinence, that they have an 86% chance of remaining in recovery. And that's great, but that 5 years will take a lot of years off your life trying to help them through it. But just supporting patients and just knowing this is a rocky, rocky road that has lots of bumps, and trying to get people, keep them alive and get them there is what we're aiming at. We know that death rates are lowered by 70% in people who are on methadone maintenance that are in treatment. So we know people do better and care. There was a health affairs study that came out that showed patients in care on methadone and buprenorphine in Massachusetts had a 76% more likelihood of staying alive, and also their comorbidities and their hospitalizations and their criminal incarcerations went down. So we know medication works, we know it's cost effective, and we know in its evidence-based scientific care that we should be providing to patients that need it. We know this disease affects people from all walks of life. People used to think differently about the heroin epidemic, the opiate epidemic, but I think that's clearly changing. We have, teenagers, they're attending each other's funerals. We have obituaries you're seeing where people are now coming out and talking about their family members. I read one the other day from a young girl from Wisconsin who wrote her own obituary because she knew that she wasn't going to make it. And it was just heartbreaking. So she wrote this in intent that she was going to die and wanted to impact other kids not to go down that road. So this is a complicated, complex disease. It requires everybody to come together. It will have bumps. There's nothing smooth about it. And the psychosocial component of it cannot be, overstated in how important that is. Treating the mental illness is critical in managing this disease. We get somebody, we're treating them, they're doing well, and they're buprenorphine, and now we're seeing depression, anxiety, and PTSD. And if we don't treat that, we're not going to manage that person. We're going to lose that person. And so having the ability to treat everything in a coordinated effort and working with all the providers is of great importance. These are some websites, the buprenorphine and SAMHSA websites, great resources. In Massachusetts, we have an addiction nurse group, which actually is the largest chapter in the country. You're always welcome to email me. I actually manage the addiction nurse group, but we also have chapter members that are in the offices. And we provide educational venues for nurses and other providers who want to go. And we do CEU trainings, and we do monthly meetings, and we do coordinated efforts around Recovery Day. And for those who are interested, Recovery Month is in September. And so trying to get involved in taking care of our patients holistically is what we're all aiming to do. Thank you.